Good evening and welcome to the North Texas Medical Society Coalition Facebook Live event. The North Texas Medical Society Coalition was formed by physician leaders in Collin, Dallas, Denton, Fannin, Grayson, and Tarrant counties. Recognizing that North Texans work, live, play, and pray in a large geographic area beyond any one county boundary, our mission is to provide North Texas with one trusted voice on health-related issues affecting our community. Welcome to this Facebook Live event. My name is Dr. Satya Bhandari. I'm a practicing pain physician in Flower Mound, Texas, which is in Denton County. Tonight's topic is what goes on in the ICU during COVID-19. I get a lot of questions from our patients about, really what's going on in our hospitals. I can understand the confusion because we don't really get an insight as to what happens in our hospitals on an everyday basis. So today's talk really is meant to give you the real facts without any political views, biases. This is just the facts of how it is in the current ICU and also on the regular hospital floors. Please send us your questions. I'll make sure that I ask them towards the end of our discussion. Without further delay, I'd like to introduce, Without further delay, I'd like to introduce our guest for the evening. That is Dr. Harshit Rao. Dr. Harshit Rao is a board certified pulmonologist and intensivist. What does that mean? Well, he is an expert on lung diseases, and not only is he an expert on that, but he's also an expert in taking care of you. God forbid you're in the intensive care unit. I just want to tell you that he is an excellent human being, very dedicated at what he does. He takes on a lot, and one of the things he's done is that he's actually the medical director for Envision Intensivists, and this is one of the largest intensive care groups in all of Texas. So he's responsible for not only being an ICU physician, but he's also responsible for taking care of the ICUs all across Texas, north, south, east, and west. I want to start off, Dr. Rao, thanking you, your colleagues, the ICU nurses, all of the respiratory therapists, and everybody that works in our ICUs. And not only that, but our floors. You truly are our heroes, and you take such commitment and you have such tenacity to keep going and to keep your patients alive and healthy. And it's unparalleled. I'm honored to have you talking with us today.
Thank you, Satya. Thank you for inviting me to this forum.
So one of the questions I always get asked, right, is what's really going on in our hospitals? Are we really getting full? Are the ICUs getting overwhelmed? So, I mean, I know you're actually coming off a shift and you're in Houston, is that right now?
That's correct. Yeah, I'm at a hospital.
What's going on in our hospitals?
The hospitals are busy. I think, almost every hospital here in Houston that I know of, not only Houston, San Antonio, Austin, all the major cities, including Dallas, are getting busier and busier. And the volume of COVID patients that we're seeing, both in the emergency rooms, on the inpatient wards, and also in the ICU. So things have certainly picked up, and they've picked up to the point where we are seeing, 95 to 100% capacity, depending on the day of the week.
So this is different than, say, last year.
Oh, yeah, absolutely. I mean, we all have busy seasons in medicine. Of course, flu season is usually very busy between September to about March. Flu seasons give you a rise in admissions, hospitals are full, etc. But this is at a whole nother level. For example, in the flu season, I would see out of, let's say, 10 patients, I would have maybe 2 or 3 that are influenza. Right now, I have a 24 bed ICU, and I have 25 COVID patients.
In the ICU?
Yes. Mhm.
Oh, wow. And so
Okay.
just remind me, how long have you been a board certified pulmonologist and intensivist?
I've been at this for about 10 years. I finished my residency fellowship about in 2010.
So you've been doing this for a decade.
Yeah.
And this is different than the last decade that you've been practicing.
I've certainly never experienced, and not just me, none of my colleagues even have ever experienced anything like this. I hope this is a once in a lifetime experience.
Absolutely, we all do. So some of the other questions I have, like, just keeping to the topic of what's happening in the hospitals. So, some of the questions I get is, who's really being admitted into the ICU? So some people say it's everybody, right? So anybody and everybody is getting admitted into the hospital. So, but I know, and you know as well, and you can please speak to this, is that when you enter the emergency room, not everybody gets admitted if you're COVID positive. So what are the criteria? So who gets sent home? Who gets admitted to a regular floor? And then who ends up in your ICU?
It's a great question. I think, majority of the folks that are getting infected with COVID-19 are getting better. I think it's important to remember that because majority of the people are healthy otherwise, and they recover relatively quickly within 7 to 10 days of having COVID. The ones that end up coming to the emergency room are the ones that are very symptomatic, meaning they're having shortness of breath, they're having cough, they're having, issues with abdominal pain or nausea, vomiting. Obviously, they may also have other associated, underlying diseases like high blood pressure or diabetes. One of the other risk factors is obesity as another risk factor. And so we're seeing patients who have these underlying conditions who then get COVID, then end up having a variety of manifestations that may lead them to an admission to the ICU. For the most part, if they're not having issues with maintaining their oxygen level normal or their blood sugars normal, their blood pressure normal, then we usually send them home. But a good percentage who have these underlying conditions are getting admitted to the hospital primarily because they're requiring oxygen. And if their oxygen saturation, which is basically a percentage of oxygen, we'd like it to be greater than 90%. And when it's not, usually you require oxygen, and that's when you get admitted. Some folks who come in really severe condition because they waited too long at home. And so they've been sick for 7 days, 10 days at home, and now are, really far along the course of COVID, and they come in basically emergent conditions where even just simple supplemental oxygen with a mask or something is not enough, and then they have to be in the ICU for other advanced ways of giving them oxygen.
So that that brings up a really good question. So when should a patient maybe reach out to their primary care doctor or go to the ER for possible admission?
I think the threshold should be very low to call your primary care physician, meaning if you have underlying diseases like high blood pressure, diabetes, obesity, and you're feeling some symptoms like cough or shortness of breath or loss of taste, loss of smell, poor appetite. Those are the ones that I see over and over again. Even some folks have had abdominal pain, nausea, vomiting, diarrhea. So any of those symptoms and you have underlying condition, it definitely deserves at a minimum a phone call to your primary care physician. Even urgent care physician if you don't have a primary care physician, and then they can guide you from there. But at the very least, I think you should be reaching out if you're starting to manifest those things.
So in the ICU, you've been doing this for over 10 years. How is your COVID floor different than a traditional ICU floor? Or is it different?
Well, it's the same floor, although we've made several modifications to our ICU and how we do things because of COVID, in order to protect ourselves, protect our our nurses and other folks, and it's partly the reason why we have restricted visitors in the ICU as well. To a minimum, and things that we've done is kind of modified the way we monitor patients, pull the monitors out of the room, pull the IV poles out of the room, even pull, in some cases, even pull the ventilators, screens and things out of the room, so we can manipulate a lot of things. Nurses can administer medications, etc., without actually having to go inside the room. Obviously, the nurses do go inside the rooms all the time. They provide care for the patients, turning them, and bathing them, cleaning them, things like that. So there's a lot of things that the nurses have to do when they go into the room, but for them, a lot of things that we've done to try and pull those things out. So, giving medications, antibiotics, etc., are easier to do.
Oh, I see. Since you're directly in charge of managing the ICU and managing your intensivists, at what point do you think about fatigue? I mean, and with managing and working the days, the long hours that you're working.
Honestly, I've been working for 7 straight days, actually more than that.
Oh, wow. 7 full straight days.
Yep.
8-hour days, or do you go more than 8 hours?
My day usually starts around 6:30 a.m. and I think the earliest I went home this past week was about 9:30.
Do you get to eat?
Sometimes you just kind of grab something as if you can. The nurses, we look out for each other. I mean, the nurses and other physicians, providers, etc., hospitals have been very generous, and we're grateful for that, and providing the sustenance for the nurses and doctors and everyone else. So we do the best we can. Fatigue is just part of what we do. I haven't really thought about it, to be honest with you. I'm sure tomorrow is a day off, and I hope, I'm sure I'll feel it tomorrow. But I think most of us try to conserve our energy and save it for the patients, and try not to think about it too much. I do worry about all my physicians. As you mentioned, I am in charge of the ICU and other physicians as part of the group as well. I do worry about burnout. I do worry about fatigue and things like that.
We lost you for a sec. There you go.
Sorry about that. The thing I tell them, and I try to make sure about, is that they have enough time off between shifts, that they are they're doing things that allow them to take away or not have any responsibility when they go home, so that they can fully enjoy their time at home. And then, of course, reminding people to take care of themselves by eating properly, making sure they're hydrated, making sure they're getting enough exercise or meditation or whatever it is that recharges a person.
Yeah.
So
excellent. I mean, I hope you listen to your own advice. So I'm just going to go on and talk a little bit about kind of the medical part of COVID-19. So I'm glad you said that most of our patients, our COVID-19 patients, are actually doing well, which is really, really good news. And so we have heard that most people, have little or no symptoms. So you're saying that for the most part, this is what you're seeing. Is that right?
thankfully I don't see them, right? So ones that have no symptoms or minimal symptoms, I thankfully they never need to see me. So that's probably even better. I would like to see them, but they don't need to see me. So I see truly the ones that are affected the most, the worst of the worst.
Here. Yeah. So so you mentioned some common symptoms, right? So you mentioned the cough and so in terms of trying to differentiate the ICU versus a regular floor, what common symptoms are you seeing in the ICU?
Severe shortness of breath, severe lack of oxygen, very, very low blood pressure, very short of breath where people are just huffing and puffing. Some folks have had issues with having altered mentation, meaning alertness. They're not alert enough.
They're confused.
Confused, disoriented. Rare cases, people have had unusual things like strokes and other abdominal, catastrophes like, a hole in their intestine or something like that. But those things are rare. Majority of it has to do with breathing and respirations where they just can't get enough oxygen in.
Are there any symptoms that are just really unique to COVID-19 that you've seen that you haven't seen anywhere else?
Not particularly. I think that it's a viral disease, so you get a lot of overlap because a lot of viruses cause similar, especially a lot of respiratory viruses cause similar symptoms. The only thing I would say about that's really unique about COVID is the lack of taste and smell. That's the one that really stands out. I haven't yet met anyone in the emergency room or admitted to the ICU that said, "Oh, I can't smell or taste and not be COVID positive." So I think that's been a little unique.
That's very unique. Yeah. So if you were to see somebody that had that loss of taste and smell, and then say, for example, came in with a stroke, right? And they were tested COVID-19, how do you know that stroke was from COVID-19 versus them having a stroke for another reason?
True. Well, it's the demographics. It's the person that's presenting. Normally 30-year-olds don't present with strokes. I mean, that just doesn't.
So they don't have any pre-existing conditions that would prompt them.
Yeah, and then that's a really great question. It's hard to establish causality. It's hard to establish that one thing led to another. Sometimes you can only correlate things. You can only put them side by side. Oh, here's a person who's COVID positive, and then here's they're having a stroke. So it's hard to do that, but at the same time, a 40-year-old person without any other risk factors, no high blood pressure, no diabetes, no obesity, no family history of strokes, no other reason to have a stroke, suddenly has a stroke, and they're COVID positive, you have to wonder in what the correlation is. And the one thing that we have figured out about COVID, it seems to somehow activate the body's coagulation system. So our body has normally, can form blood clots because, obviously if you cut yourself, you have to stop bleeding somehow, and your body takes care of that. The virus somehow activates that clotting pathway and ends up causing unnecessary blood clots that are sometimes leading to these types of events like strokes or blood clots in the lungs and so forth.
Do you just put them on? Do blood thinners work in those cases? You put them on heparin? What do you do?
Yeah, so one of the most common blood thinners that thins your blood and prevents blood from clotting is called heparin. There are similar other molecules, chemicals, compounds that are prevent clotting in your body, and so that's what we do. We put these patients on blood thinners. We're obviously monitoring certain laboratory parameters to determine that, and then we put them on blood thinners.
So, and that works for the most part?
Oh yeah, absolutely. We have, since we figured that out, we haven't had any events like that where we have led to severe blood clot formation that I can think of. There are rare cases where certain individuals may not respond to heparin either, and may have to go other agents.
Mm-hmm.
But those things are rare. Again, for most people, heparin is just fine.
Yeah, so then let's go on to talk about treatment. I think this was a really good segue to talk about what's changed. So we've heard a lot about remdesivir, hydroxychloroquine, convalescent plasma are in the media, but I've never used these things, and I'm sure you've probably used them. What's your experience with using these, and are they effective, and what kind of results are you seeing in your patients in the ICU?
I think first and foremost, I think the thing that it's probably been heard in the media the most is the remdesivir trial, because it was obviously Dr. Fauci announced that to the world and sitting in the White House. So I think most people are aware of that one. That drug is available. It is still in short supply. We are getting, I would say, a steady allocation week after week. We do tend to sometimes run out by the end of the week, but we try to keep up with that. The hospitals do, at least. The patients that are benefiting from those, and there are patients benefiting from that drug, are the ones that are on oxygen, the ones that are requiring admission to the hospital, either on the inpatient wards or in the ICU, and some of them are getting better. And the sooner, the earlier we start the remdesivir, the better the outcomes have been. Is the observation that I can tell you.
Tell me about convalescent plasma. What is it? How do you use it?
So it's pretty simple. Convalescent plasma is basically extracting that component of our blood that has antibodies in it. And so presuming that someone who recovered from having COVID-19 and got the infection and then got over the infection is no longer sick with the virus is gone from their body, extracting the plasma, the component with the antibodies, will have antibodies that will work against COVID. And so we take that component, that plasma from a person who's recovered, which is caused convalescence, and hence convalescent plasma. We take that convalescent plasma and then give it to a person who has COVID-19, who is having symptoms, who hasn't gotten better yet. And by giving them this convalescent plasma, what we're really doing is giving them antibodies against COVID-19, which we hope that the antibodies will help the recipient's bodies fight off the COVID.
Have you seen results? Have you used it yourself?
Absolutely. We do it on a daily basis. It's one of the things that we do first thing as soon as they hit the door. You have to be type and screen, so we have to know your blood type, and then we request the convalescent plasma from a local blood bank, which is now convalescent plasma. Is now widely available almost in every facility. And we're able to get it in a very short period of time, and it is effective. It is part of.
Go ahead.
And I was just going to add that it's part of a national trial under the umbrella of the Mayo Clinic, and we're all required to register every patient with that trial.
So the plasma is from blood, right? So what somebody would do if they've gotten better after having COVID-19 and they test positive for antibodies, they could donate their blood. Is that how you would get the convalescent plasma?
Correct. Yeah, you have to. I mean, it's a multi-step process
Yeah.
to qualify to be able to give convalescent plasma. So you have to, meet a whole bunch of criteria. You have to do a whole bunch of testing, make sure that you're not infected, not just with COVID, but you're not infected with any other virus as well. So there's a whole selection process, and that goes into that. But it does help. It does work.
So something I've also seen in some of the ICU pictures are the patients that are prone, that are on their stomach. And that's something that we haven't seen. And I think we learned from maybe Europe, or you can tell me. And so why do you all do that in the ICU? Why does that happen?
As a long explanation, but I'll try to shorten it.
Short explanation for a dummy like me.
Basically, we are creatures that are meant to walk on our 2 feet, and we sleep on our backs, and that's just how we're designed as human beings. And gravity follows blood follows gravity, and so our blood tends to pool in the lower halves of our lungs, where the blood picks up oxygen in the lungs. When we lie down, similarly, it pools in the back half of our lungs, and that's where it picks up oxygen. And interestingly, when people get sick with COVID or any other virus, any other disease, matter of fact, the infection tends to be in that part of the lung. So the lower parts of the lungs, the back part of the lungs, when we lie down, those are the ones that are most affected. And so the idea is for the blood to go, and to add to that, where there's infection, there's lack of oxygen, right? If blood is going to areas of the lungs where there's lack of oxygen, it's clearly not going to have an opportunity to pick up that oxygen from the air that we're breathing in. So you flip them over. If you flip them over, now that your chest is on the bottom, that's where the blood is pooling. That's where the air is. That's where the oxygen is. And then the blood and air meet together, and then you can pick up more oxygen, and your oxygen level go up.
That's
so
amazing.
It's just as simple as that. We've turned human beings into pancakes, but that's
for a good reason.
For a good reason.
So let's talk about this. This is a novel coronavirus, right? So this novel meaning new. So we don't know a lot about this coronavirus. How do you, now it's July, how do you know what to do? Do you know it from other countries, or where are all of you getting your ideas for treatment from?
Yeah, it's a great question, actually. So in the beginning of this pandemic, obviously we did not have a lot of information, and primarily when it was in China, we had to wait. We had to wait till the doctors and the scientists in China started publishing and writing about this disease, and telling us what they were seeing and what kind of labs they were doing, and what complications they were having, and what medications they're trying to help fight this disease. And that's how the information started coming out. And then once COVID started spreading more globally, more information came out of France and Italy, and then of course the United States, and a number of different scientists and physicians, doctors, nurses, etc., showed extraordinary amount of collaboration by calling each other, reaching out, like, hey, I'm seeing this, what are you seeing, and so forth, and then collaborating to write up papers in a furious fashion. I've never seen so many articles come out about a disease in such a short period of time. And I can tell you, Satya, that between I would say March 14th and about end of April, I personally may have read over 100 articles on coronavirus and COVID-19, and and assimilating one of my jobs as a regional medical director is to try and assimilate all this information as much as I can, and then disseminate the pearls to our other physicians, and collaborate with them, because they're obviously starting to see COVID in their hospitals, and say, hey, I read this article on convalescent plasma. Is it available there? And let's see if we can find it for you, and that kind of thing. So that's how it all started. Just a tremendous amount of collegiality, sharing of information, lots of smart people doing trials and figuring out what drugs are working, and so forth. So
yeah, those are also our heroes, right? And the people who take the effort to publish their findings. And truly, I mean, we are doctors, and we do not have borders.
Yeah, and
yeah.
the thing that amazes me is that for example, I'm working here for 7 whatever it is days is, and after my little shift is over, to go home and to put all those things you learn and put them down on paper and write a paper and get it out there, so your other colleague, I mean, that must have taken a tremendous effort. And so I really salute and respect those people.
Absolutely. Yeah, we do have to, and we wouldn't be here without it. So I thank all of them for doing that as well. I just wanted to, there was a question that came up about ICU patients that are on ventilators. In your opinion, in your practice right now, how many of those patients are surviving extubation and then getting onto a regular floor and even walking out of the hospital?
I think we're getting better. I think we're definitely getting better compared to what it was 2 months ago, for sure. Maybe 3 months ago, March. Yeah, 3 months ago. I don't know if I can give you a solid percentage on how many are getting better and walking out, but majority are getting better and walking out. Again, what we're seeing is folks getting really, really sick, and it takes time. Sometimes 10 days, sometimes 2 weeks, sometimes 4 weeks, but we continue to stay with it and monitor them and manage them, and give them the therapies, sometimes not once but twice or thrice, as many times as it takes, to see if we can get them better.
Are they staying in the ICU for 4 weeks?
Yeah.
Oh,
yeah. And
wow. Okay.
And that's the complication. It's not that we don't have the capability of taking care of these folks. It's the capacity, and the capacity becomes an issue only because once you're in the ICU and you really are that sick and you need to be in the ICU, for 2 weeks, 3 weeks, 4 weeks, those beds get filled very, very, very quickly. And that's why there's no space in the ICUs. It's not because
it becomes an accumulation of
Exactly.
patients that are not being able to be discharged. Wow. So let's talk about some kind of difficult topics here. What kind of difficult decisions do you make on behalf of patients when you're in the ICU?
That's I try not to. Number one, we try to use resources as wisely as possible and as much as possible. We beg and cajole and trade and do whatever is needed to get the medications or drugs or that we need for our patients. And so it doesn't come to that too often. But there are times where we get, low on resources, and, ventilators, dialysis machines, filters that go into dialysis machines, other medications, like I mentioned, remdesivir has been in a little bit short supply. I mean, those kinds of things. So you do have to be sometimes prioritize which ones are going to get that therapy. And those are not easy decisions to make for sure. And the way we do that is, certainly prioritizing the ones that are younger and have a really great chance of recovering. Those are the ones that we really try to focus on, and try to get them the best, and all that we have available. That is not to say that the ones that are not and are not going to get that therapy. It's just that, sometimes you just have to make those calls.
Difficult decisions. Yeah. I think another difficult decision that is very unique to COVID-19 is the isolation of patients away from family members. I think that's something that's new.
Yeah.
It must make it very hard for the family members to be able to even see their family member that's in the ICU. So how do you talk to those families?
It's very tough. Actually, just this week, and then others have done the same thing, but just this week, I spoke to our administration here at the hospital, and I said, we need a dedicated person that can go around with an iPad and FaceTime their family members with their patients on a daily basis. The patients that are on ventilators are certainly not going to be able to do that for themselves. We are not allowing visitors to the hospital unless it's really dire, emergencies or circumstances or what have you. And that's for their protection as well as ours. But so we and the administration has been, most hospital administrations have been really wonderful to work with. They have provided those resources, those iPads and those folks that can come in and do those, have those conversations, even for 5 minutes, show the patient's face, their loved one's face on the screen, so they can see what's going on and know. On a more personal note, I can tell you in the last 7 days, I just have to prioritize. I look at my list and I say, okay, this family I haven't talked to in 2 days, I need to call them, and kind of, prioritize on those things, be selective, because there's only so many hours in the day and there's so many things to do. At least one member from the team is staying in touch with the family on a daily basis. So whether it be a nurse, whether it be one of these patient care coordinators, whether it be me, whether it be my nurse practitioner, one of us is reaching out.
What kind of emotional impact do you think this type of, the positive, at least you guys are being able to talk to each other through FaceTime, or at least see their family members? Like, what kind of emotional impact do you think this is having on the family when they can't see somebody and then they see them again?
It's terrible. I think the first thing that goes away is trust, right? I mean, you just don't know, because you can't see and because you can't feel, can't touch, and it doesn't get internalized. And so it just becomes very surreal for folks that this is happening. And of course, folks that are at home and don't have that opportunity to see their loved ones, where facilities that may not have these resources, they just assume that their family members are being taken care of and that they're getting better and that they'll be home someday, and so on and so forth. And yeah, that's true for majority of the patients, but it's not true for all. And that is where the difficulty lies. And I have made those phone calls to patients' families where I don't have good news and I have to share bad news. And I try to be truthful, and I try to be honest about what I'm seeing and what we have done, and what we are doing, and try to give them the most accurate picture that I can, where certain decisions have to be made. So.
Yeah. I think communication is key, but
Yeah.
right, there's only so many minutes in the day, and when you're fighting for somebody's life for those 8 hours, it's hard to come away from that. I completely understand. I just wanted to ask you about the comorbidities, or what, in other words, the other health issues that you're seeing patients have that they're coming in sicker, that are requiring the ICU. And you mentioned that a little bit earlier on. Can you mention those again for me?
Yeah, I think we talked about the diabetes and high blood pressure and obesity as being one of some of the major things. We are been afraid of people who are elderly, obviously, folks that are 65 and over or 75 and over. The older you are, the more likely it is that you may die from COVID. And so those are really vulnerable populations. Thankfully, the folks, the elderly population have done a great job of isolating themselves and social distancing and so forth. So I think that's been a great thing.
What's the average, Dr. Rao, what's the average age right now in your ICU, do you think?
Oh, average. I have patients ranging from 32 right now, 32 to about 77. And I would say average is probably around 50, 54, 55, somewhere in there. It's it's relatively young.
Yeah. So when they leave the ICU, they go on to a step down unit or a recovery unit, something like that. So do those patients have any long-term side effects when they're finally discharged?
Oh yeah, critical illness. Being in the ICU is no joke, and the medications we're using are no joke, and they are heavy sedatives that we're using, which can cause a lot of cognitive issues with patients when they come off these heavy sedatives. So, folks are known to have, such a thing as ICU brain, right? That that confusion, that sort of disjointedness, stays with them for a long period of time. It takes a while for them to kind of get back to normal. And we're seeing a lot of that. We're actually seeing, thinking that some of this has to do with COVID as well. One of the things that COVID causes is this confusion, this agitation, this irritation of the brain. We feel is also contributing to that.
Is that like an encephalitis or something to that extent?
Yeah, something of that sort, and inflammation of the brain.
Okay.
But also, extreme, profound weakness, right? Muscle weakness. Lying in bed for 14 days straight, not moving a muscle. You tend to lose a lot of muscle mass. Tend to lose a lot of body weight, and you become extremely malnourished and so forth. I mean, even though we're feeding these people and watching out for them and so forth, there's just no substitute for being, up and walking.
Oh, wow, and walking. Yeah, absolutely.
What you don't use, you lose, right? And that's what happens to these folks. So rehab, debility from debility takes a long time. It is said that for every week you spend in bed, every day you spend in bed, you need a week of rehab, and that's pretty much true for all these folks.
Yeah, so these people are spending sometimes 4 to 6 weeks in the ICU, let alone they've been probably ill for a few weeks at least prior to that. So, and then now they're spending maybe 2 to 4 weeks in a rehab unit trying to learn how to walk again and possibly, eat food. That's almost 3 months out of somebody's life. That's pretty significant. There was a question here about vascular complications. We talked about that, like stroke and heart attacks. Do you think that the vascular complications have some correlation to worsening clinical status?
Yeah, absolutely. I think that patients who have issues with their blood vessels, forming blood clots. It certainly leads to more complications. One of the things that we've seen is the kidney failure that comes along with that. So a lot of folks who have COVID and get really sick tend to get kidney failure as well. So along with their lungs being an issue. We tend to sometimes, the sooner they present and the sooner we start the blood thinners and all these other therapies, the better they do, the more we're likely to avoid these complications. But they do happen.
So let's get on a personal level. Let's talk about your health and your staff and the ICU nurses. Are you seeing a higher rate of COVID positive healthcare workers?
Thankfully, most of the providers, most of the healthcare providers are normally are healthy. They don't have a whole lot of other underlying medical issues and so forth. So, we do get infected. I forget what the exact percentage of healthcare workers getting infected are. There was a large percentage of healthcare workers getting infected, and I believe it was Italy, where the pandemic really, took a toll. But in the U.S., thankfully, with the PPE we have and the hand washing and the cleaning, being extremely careful with your personal hygiene, we haven't had too many of these folks getting sick or dying from COVID. There have been certainly folks who have. I mean, I don't want to minimize that or at all. And most of the healthcare providers who are getting COVID are getting better.
That is that's wonderful to hear.
My team alone, I've had out of 70 plus folks in our group. I think we've had about 10 that have gotten infected with COVID and recovered.
All recovered.
Mm-hmm.
Thank goodness. Before we end, I'm just going to ask you some questions. It must be very stressful. I can't even imagine, and very intimidating, that I can imagine, to be responsible for someone's life. Why do you do it?
It's a good question. I don't know why I do. I have always been that kind of person, I guess. Intensivists, such as myself, I'm a pulmonary critical care doctor. There are other doctors who are intensivists, just trained in critical care. And we have a different way of looking at things and how we approach life, and how we like to know and learn and treat people in a different way. We're kind of, I guess, attracted to the critical nature of the work and how sick people are, and knowing that there's something that I can do about that. It brings a level of personal satisfaction, and so I guess that's the reason. And most, the interesting thing about intensivists is most patients will never know who their intensivist was, right? So because most of them are too sick to know who's taking care of them.
So you don't get flowers or cakes?
No, we don't.
Mental note, everybody. Send your, God forbid you ever have to have an intensivist, send him or her flowers.
That's not what I was saying. What I was saying was, it's a good thing. We like it that way. We like that our patients get better and they never have to know who took care of them, because that's just the kind of that to me is true doing it for the right reasons, basically.
Absolutely.
Is what
What does your family think about what you do?
Oh, they all think I'm crazy. they they are they're amazed. They just shake their heads, and they can't But at the same time, I think I'm sure most of my family members think that they wouldn't be able to see me doing anything else. So it kind of goes along with the kind of person I am, I guess.
Kind of person you are. Absolutely. This is a tough question, but I'm going to ask it. Have you ever thought about how this job could hurt you or your family?
Could hurt, you said? Is that what you said?
Yeah.
Oh yeah, absolutely. Yeah, I was just thinking about that the other day, and I was thinking, did I update my life insurance policy? I did think about that, and I quickly went through my head, and I said, yeah, no, I'll be okay. So yeah, I mean, it's part of life. I mean, you do the best you can, and hope that everything that you're doing is going to, add a lot of good karma to your life, so that the good things will happen to you. So,
is there anything that you'd like to say to our audience today before we end?
I would only say that please, wear your masks. Mine's right here. You have to wear your masks out in public, and stay 6 feet away from people, and do your social distancing, wash your hands, don't go on unnecessary errands or combine your errands into one trip. Do the best you can to protect yourself and your family by staying away from other people. I think that's the only way we're gonna slow down the spread of this virus, and give the doctors and other scientists an opportunity to find a cure, to find a vaccine, to find something that's going to relieve us from this awful disease. So we just need time, and the only way to buy that time and prevent further life loss is by doing the social distancing and the wearing the masks and hygiene.
Absolutely. Well, this concludes our Facebook Live event. I on behalf of North Texas Medical Society Coalition, I want to thank you, Dr. Rao, for spending the almost hour with us. I know that this was precious time for you to de-stress, but you were able to do that and spend that time with us, and also for answering all the questions. I thank the audience for listening in and asking your questions. Please follow us on our Facebook page for the latest medical advice, and be safe, Texas. Thank you, everybody.
Thank you. My pleasure.